Okay, so I am Larry Brody. I'm the director of something we call the Division of Genomics and Society, which includes 3 areas at NHGRI. Our ELSI research program, which you'll hear a little bit more about later, our Education and Community Development branch, which is the host space for ISCC-PEG, and our policy group, which I don't think we have on the program today, but we might bring them to you later. And so it's my pleasure to introduce the Scholar program, which I think is an amazing way to do multipliers and essentially start to seed the next generation of researchers and practitioners and educators that are aligned with the mission of ISCC-PEG. And so we're going to have 3 scholars present, and they'll be introduced by their mentors, 2 of which will do so from remotely, I think, or is the second one here as well? And the third scholar presentation I will introduce. Yes, her mentors are not available today. So I'm going to hand over the introduction to, I don't have the name of the scholar, Louise? Louise?
Louise.
Louise, thank you, Louise. Now I see you in most.
Great, thank you very much. I've been delighted to work with Abimbola Oladayo over the past year and a half. She is a dentist trained in Nigeria and is now finishing up her PhD in oral science at the University of Iowa. She's had over the last several years an interest in genetics and craniofacial malformations, being involved in some of the larger studies that were done out of Africa. She's looked at various components of how to disclose secondary findings from the African cleft cohort. She's looked at what provider knowledge has been when returning secondary findings. And she's looked at how this has impacted the families and the community gatekeepers and their knowledge and ability to disseminate genetic information. She was enthusiastic about working with the OB-GYN group as we tried to look at ways to better improve genetic knowledge among the women's healthcare providers. So I will turn it over to her.
Thank you for the introduction, Dr. Louise. Just waiting for them to pull up my slide. Okay. Do I get to see the notes from here or not? No. Okay, I'll just go on. So, good morning, everyone. Again, I'm Abimbola Oladayo, and I'm a third year PhD at the College of Dentistry, University of Iowa, also a T90 fellow, and I'm a member of the outgoing class of scholars. And I have the pleasure of being mentored by Dr. Louise Wilkenhoff. I would like to thank you for giving me the opportunity to present research or this update on the project that we're working on reviewing genetics and genomics resources for OB-GYN professionals. And as an overview, the goal of the project is to look at improving access to genetics and genomics education resources by creating a central resource point consisting of up-to-date information. And we know that quite a lot of effort has gone into creating resources and tools for providers, both genetic and non-genetic providers. But looking at the available resources, quite a lot more could be done to making these resources available and making it a better fit for the target audience. And by the virtue of my involvement with the OB-GYN working group, this project is going to be looking at OB-GYN providers. So we know, or by the increasing knowledge of, I don't know why that is cutting off, but by increasing knowledge of genomic technologies, we are beginning to see the increased use of these technologies or their application to diagnostics, prognostics, treatment, and prevention. And it just falls down to the point that providers would need to be aware of these resources, basic principles, and also how to interpret these the outcome of this testing so that it can be useful for providers and also for patients. And in the context of the advances in genomic sciences, it's moving all across medical practice, including OB-GYN practice. And as said before by Dr. Green, we have DNA-based tests for pre-implantation, prenatal and postnatal diagnosis, carrier testing, and employee screening, and also gynecological malignancies. And the lack of knowledge or knowing about these testing options or the lack of thereof might be a problem and might impact treatment and preventive approach to fetal and maternal care. Thus, speaking to the need to make sure that providers in these specialties have up-to-date information on these technologies. Although a lot has been said about the role of these emerging technologies in healthcare, very little is known about low levels of genetic literacy or genomic literacy still persists in non-genetic healthcare providers, including OB-GYN professionals. And this is seen in the limited knowledge regarding testing options available for patients, having low confidence about using genetic tests in patient care, having a limited knowledge about how and when to make a referral to a specialist, and in conducting risk assessment and using various information in care decisions. Another problem is with the shortage of genetic counselors across the nation, OB-GYN might be called on more often to fill these shoes. So they would have to be prepared knowledge-wise and also to have the resources to refer patients if they need to. All of this would impact the delivery and incorporation of genomics into healthcare. And talking about all of this, what barriers have been identified to providers genomic education? And from literature, this includes time requirements for elective education, commercial or for-profit entities as major sources of information, the pace at which we have genomics technology advancing, and the rates that the available resources are being updated, not being the same, and also providers' awareness of existing educational resources and how easy it is to navigate these resources. And I have tried to scour the internet for available resources, and one of the barriers also was seen on the American College of Obstetrics and Gynecology's website, which is supposed to be a website or source of information for these providers. And on the website, you had this disclaimer saying this document reflects emerging clinical and scientific advances as of the date issued and is subject to change. Another disclaimer was that these resources are for informational purposes only and are not meant to be comprehensive. And even when you have links like for more information, click on this, it takes you to a page that is not active or says page not found. At least it was still not active as at this morning. So this dead ends might be frustrating for providers that are trying to look for information for their patients. And lastly, this abstract published in the American Journal of Obstetrics and Gynecology, which was a cross-sectional study of prenatal care providers' knowledge, barriers, and confidence in prenatal genetic counseling, including OB-GYN providers, found that this provider spent too little time on genetic counseling, and more than half would not correctly identify the ACOG's recommendations. And the barriers listed included time constraints, health literacy, lack of a visual aid, and language barriers. And one thing again that was striking was that more than half could not correctly identify the American College of Obstetrics and Gynecology's recommendations, meaning that the specialty bodies in charge of educating or promoting health literacy of providers are trying to do a good enough job of putting these resources out there. But what's the disconnect between putting out those resources and the understanding of the providers or the members of the organizations that these resources are being curated for? The future directions recommended from this study was the need for the development and assessment of prenatal genetics educational tools to supplement counseling. So putting all of this together, the pros and cons of the available resources, we tried to do a literature review using Google Scholar and PubMed, and also looking at websites of scientific, clinical, and professional organizations. So for the available resources, some of these resources have been mentioned earlier by Donna. We have some from professional organizations, and this includes ACOG, AMA, ACMG, and those out of the United States, such as the ESHG. We also have those from public databases, and this would include information ranging from basic genetic terms or principles for providers and for patients, and also to point of care resources for providers based on what or the need of the provider or the patient at any point in time. And also government-supported programs. And the largest or most extensive was found on the NHGRI's website, which was also has been talked about this morning. And we have several, but I'll come back to the OB-GYN project in the recommendation section. And I need to clarify that government-supported programs, what I mean by that is that resources that were curated either in a government institution or are being funded by government funds, and this could be either state or government or federal money. And that's why I have state health departments. For public health departments across each state, they have varying resources, either for providers or for patient education. And there's also nonprofits. For nonprofits, it could be online modules or web-based modules. And there's also a repository of resources in genetics education Canada. This you could either create access by registering and all of that, or you would have to be a member, like the Genomics education program for the health educations England. So you either have to be affiliated with a UK institution or with the NHS. So putting all of this together, and because most of the resources were web-based, the question is, are web-based genomic education approaches effective, looking at some of the cons that have been discussed? And this study that looked at improved provider preparedness through an 8-pack genetics and genomics education program showed that web-based education is indeed highly effective in increasing providers' confidence about using genetics. So if the portal of providing the information or disseminating the information is quite good as being reviewed, what else can be done to make these resources better or serve the purposes that they were created for? And number one is to make providers have a better understanding and the need to support their patient post-testing or during the return of results. And this would involve having the adequate knowledge to know when and how to refer patients to genetic counselors. Currently, for OB-GYN providers, it might be a bit complex for them to do this on their end, and there has to be a way to let them know that genetic counselors might be collaborators or allies to making patients understand or making their work easier in that way. And the second issue is to improve providers, make them familiar with practical and ethical issues. And this would include patient privacy and also returning or withholding information for patients for at risk and also their families, and also returning secondary genetic findings and the complex ethical issues around this. Again, there was a scarcity of information or resources on this, particularly for OB-GYN providers, and also reviewing the available educational resources just so that it serves to provide the resources, the information that providers would want. And in this case, we could look at organizing these resources using keywords and common categories. And I tried that on the Genome Ed website. You're looking for using keywords like OB-GYN or GYN, and the only resource that came up was the OB-G project that I said I was going to talk about earlier. This is not a government funded resource. It's by what I found on it, it said this resource is for provider and by providers, and it's supposed to be a mobile-based resource, which is free for providers to be able to get more information on women health issues. And the next thing that we looked at is to look at how providers' awareness can be improved about available educational resources and having a clear plan for dissemination. As I mentioned, specialty organizations such as the ACOG, AMA would have a database or a way to reach out to their members. But for resources that are created outside of specialty organizations, how do these resources reach the target audience? So to bring all of this together, is there a way that an alliance could be proposed that would consist of multiple organizations to develop standard and central educational approaches? And since the ISCC-PEG has started this work, is there a way that ISCCG can play a role in coordinating these educational resources? These thoughts are ongoing and they are evolving. And as we continue to research towards the end of my project, we may add things to these or remove from these discussions and recommendations for our final report. And I would like to acknowledge my mentor for our time and efforts and recommendations on this project, and also the co-chair of the OB-GYN working group, the ISCC-PEG co-chairs, Rich and Donna. Thank you for all you've done since the beginning of the fellowship, the NHGRI for putting this program together, and also my training lab and funding responsible for my training. Thank you for listening, and I'll take questions now.
Oh, I was gonna say, Rich, I can jump in as well. I was gonna say, we certainly would welcome any comments from the group as to how to bridge this gap. We thought about, we will still follow up with like a paper on, state of the resources for the common OB-GYN journals, because I think it really is a challenge to know where to go that's not commercial to get both information for yourself and for the patient.
Please press 1 to join the meeting. This meeting is being recorded. You are in the meeting now.
So we're in the meeting now, just so you know.
Okay, I was gonna say, I thought it was a fire alarm. Yeah, so that's one thing, and, certainly submitting it to something like the ACOG meeting, trying to get, a state of the resources paper out there for OB-GYN genetic resources. But also, I think the biggest challenge is how do you keep it updated? And that's why we were wanting to open this up to the, ISCC, and whether this would be a role that they could serve.
I think part of what we've been trying to do at ISCC-PEG is bring together people. The issue becomes every organization and every specialty has unique needs and ways that they find things out. And it's one of the reasons we talk about whenever you're starting a project, you have to figure out how it's going to be disseminated. Because unfortunately, there are cases where people create things and then no one can get to it or it can't be posted.
Yeah.
So, but I think it's definitely something we can talk larger, or even a more general format that people can use. So I think anything we can help with. I'll just take one. We have one for Siddharth. You had a question, and then we have to move on.
Yeah, Siddharth Prakash, Houston. Great presentation. It raised some important questions. One of the rate limiting steps we find in adult medicine is that there are very few genetic professionals in many parts of the country. There's a huge gap in the workforce, and so even if we tell people, you can recognize genetic disease and refer your patients, there's often no one to refer them to. Are there any resources that you found that help connect non-genetic providers with genetic professionals in order to make this more of a collaborative process?
Thanks for the question. So as I've said, the thoughts are still evolving, and I haven't looked at that yet. Looking at connecting non-genetic providers to genetic professionals, especially in the context of OB-GYN practice. So it's also something that can be added to this report as that we go on with the preparation. And thank you so much for that comment.
I will say, I'm guessing that NSGC or ACMG have, Emily, can you put in the chat maybe if you have a link?
Yeah,
Just because we're running a little short on time. But
both organizations do have tools.
So maybe we can put
professionals.
those in the chat because I think it's a really important point, and I think those organizations, and there might be others, please, if there are other organizations that have tried to facilitate that, I think please put it in the chat. But anyway, thank you very much, and thanks for all your work. And it seems like there's still some stuff to do, so that's good. So, all right, who do we have, Donna? Who do we have next?
You want?
Oh, you're introducing each person.
Yeah.
No, that's fine. Sure.
Yes. So we're doing in-person, virtual, in-person. The next speaker, I believe, is virtual. Yes. Thank you. And it's Katharine Callahan, and she's going to be introduced by her mentor who was in the room, Sabrina Jenkins.
All right. It is my honor and pleasure to introduce Dr. Katharine Callahan. She did her medical school training at Johns Hopkins University, her pediatric residency at New York Presbyterian Morgan Stanley Children's Hospital, and is currently doing a neonatology fellowship at the Children's Hospital of Philadelphia. In her spare time, she's also completing a master's in medical ethics and postdoctoral fellowship in ethical, legal, and social implications of genetics this year. So working with the rare disease group of ISCC-PEG, KP's project aimed to examine the variation in genetic testing between neonatal intensive care units across hospitals over time. Her analysis included 207,228 neonates from 38 hospitals and was published in Genetics and Medicine in December of last year. It was a pleasure to work with KP, and I expect that we will see a long career of accomplishments in this field.
Thank you for the introduction. And I'm sorry I can't be there in person. I have a 6-week-old who hopefully you will not hear in the background. And with that, I'm going to share my screen. Can you see my slides?
Yes, looks good.
Thank you. So thank you, Sabrina, for the introduction. As Sabrina said, I am a fellow in both neonatology and the ethics of genetics at CHOP and Penn. And this project came at the confluence of these interests. This was actually a project that I began before the ISCC-PEG Scholar Program and had just not really figured out how to put together. And Sabrina's help as a fellow neonatologist, also interested in similar questions, helped me complete the project. And as she said, we ultimately were able to get it published. So the background of this is really the background of all of my recent research. The NICU has been a launching point for genetic testing, and this makes a lot of sense because genetic diseases are very common in the NICU, and there's also a need for better prognostic information. However, this generates a lot of information, this type of testing, and how exactly we should use this information is unclear. So my research overall aims to address the ethical implications of genetic information in the NICU. These includes questions such as how do neonatologists actually use genetic tests in practice? How should they use genetic tests? How do neonatologists apply genetic information in making difficult decisions? How do they apply it in difficult decisions, particularly when they portend to end-of-life care? And in this project, I zoom out a little bit and just say, at a hospital level, how are NICUs using genetic testing differently? And the goal here was just to examine variation between hospitals. So there are no guidelines to standardize testing in NICUs, and each hospital is left to its own devices to develop policies and practices. There's also dramatic variation between states and between insurance companies and coverage. And so at the start, it seemed likely that there would be variation between hospitals, and generally extreme variation is considered to be a marker of poor quality healthcare. In this particular case, there are risks of both too little and too much testing. The risks of too little testing are perhaps more obvious, that some patients might be denied the benefits of genetic testing based solely on where they're born. The benefits of too much testing, I think, are only at earlier stages of understanding, but a lot of my work is in this area, that, you know, when we have a lot of information, especially uncertain information, and we're not sure how to use it, this can have confusing or even harmful effects on both neonatologists and also on families. So what is the right amount of information? Actually, that's kind of a leading and misleading question, because the goal of this wasn't to answer that, but just to say that we don't really have a clear explanation of what the right amount is. And I think most people agree that too little or too much could be a problem, but the goal here was really just to describe genetic testing practices as a first step toward assessing the need for standardization. So we performed a retrospective cohort study using NICU discharge data from the Pediatric Hospital Information System database, which is called VIS. And we used data from 2016 to 2021, which of course was a period where genetic testing evolved a lot. VIS is a database of patient-level care from 49 freestanding children's hospitals. And overall, our objective was to analyze variation in genetic testing among hospitals over time. We had a medical geneticist, who happens to be one of my NICU co-fellows, curate a list of what qualified as a genetic test based on the billing codes that are available in VIS, which are CPT codes. And the primary outcome was the percent of NICU patients who underwent any genetic testing. So we calculated in each NICU in each year, the percent of patients that underwent any testing as a sort of dichotomous yes/no variable. We analyzed variation in the percentage of NICU patients who had genetic testing between hospitals and over time. And then we used multivariable, multi-level logistic regression to investigate the potential impacts of patient characteristics and hospital characteristics on this percentage of genetic testing. And in this model, we looked at a bunch of variables: length of stay, admission year, gestational age, mortality, sex, race, ICD codes, lab tests, codes that represent both congenital anomalies and complex chronic conditions, and the APR-DRG, which is a standard measure of illness severity. We also looked at whether the infants were inborn or transferred, and the number of clinical geneticists, which I just extracted from the hospital websites because it isn't available in VIS. Ultimately, our analysis included nearly 200,000 admissions from 38 hospitals. We had to exclude some of the hospitals because they were missing data. Of the included admissions, 13% of patients had at least one, or 13% really of admissions had at least one genetic test associated. And over the study period, you can see here that the trend was toward increases in testing. So a higher percentage of patients are tested in more recent years. And then these dotted lines, the top one is the high testing hospitals. That was the 5 hospitals that did the most genetic testing. And the bottom line is the low testing hospitals, the 5 hospitals that tested the lowest percentage of patients. And as you can see, the high testing hospitals are increasing at a much greater rate than the overall, and the low testing hospitals at a lower rate than the overall. So this increase is really disproportionately borne by certain hospitals who now test a very high percentage of patients. Between hospitals, the percentage of patients varies dramatically, from 4 to 41%. And we sought to investigate the extent to which this was related to patient case mix, or really like the way you could think about this is average illness severity, because it makes sense from a clinical perspective that some units have sicker patients, and those ones do more testing in general of all kinds, but particularly genetic testing. Unsurprisingly, as I suggested, on average, patients who received genetic testing had higher illness severity, and this was reflected by several patient-level characteristics. This group was marked by higher mortality, length of stay, complex chronic conditions, congenital anomalies, and severity level. And these patients also had lower gestational age, which also makes sense because, higher gestational age, because patients who are hospitalized just for prematurity probably are less likely to need genetic testing. And then we also looked at some of the demographic factors and found that Black patients who parents identified as Black were less likely to undergo genetic testing, and sex was not a significant variable in this model. So then we plugged all of these factors into the multi-level logistic regression model and saw, like, if we basically correct for the differences between hospitals and all of these factors, how much variation in genetic testing is left. So here, basically, we fit a pair of models that had differing fixed effects. The model on the left is an intercept-only model that just shows the variation in genetic testing. It's the one that I showed you before, where there's just a big range in genetic testing. And the model on the right controls for all of the factors that were significantly associated with genetic testing. And as these figures suggest, there is minimal decrease in the variation that is accounted for by differences in case mix. So in between these two models, basically variation between hospitals accounted for 13% of variance in the first one and 10% in the second model. So a lot of this variation is not related to patient level variables, at least the ones that we plugged into our model that were available in FIS, which is a limitation I'll talk about more. As a secondary outcome, we also looked at the mean number of tests per patient, and this has some limitations of its own because the way we looked at genetic tests, as I said, was only through billing codes, and they're an imperfect measure of like the way clinically you would think or talk about a genetic test. But nonetheless, there was a lot of variation in also the number of genetic tests per patient for the patients who did undergo testing. And generally, hospitals that tested a greater percentage of patients also sent more tests per patient. So as I've alluded to, there are limitations of this methodology, and we interpret the data within the confines of our methodology here. So we were using a large-scale database. There's only certain data available in there, and that was the only data that we could use to control for in the multi-level model. So there are other variables you can think of that might affect, like the need for genetic testing, for example, that we aren't able to control for. We were limited to what's in FIS database. This, for one example, is that this excludes research testing, which probably wouldn't be billed and therefore wouldn't be available in FIS. And as many of us in this group are aware, like a lot of genetic testing is still done on a research basis. So this was missed. But we expect that, if anything, this probably increased the variance rather than reducing it, because research is often done at places that also send a lot of testing through clinical means. So the underlying question of this is, was the testing appropriate? And we can't directly address that question here. All we can do is say that there's a lot of variation in the percentage of genetic testing in between hospitals in their NICU. So patients in different NICUs undergo genetic testing at very different levels, and this is increasingly so over time. Variation is not adequately explained by differences in patient populations, at least as we were able to represent them from the FIS database, which is many, or probably I can say most, of the variables that have been associated with genetic testing in more in-depth studies. So the resulting question is then, all right, what does explain the variation in testing? One interesting correlation is that between the percent of patients tested and the number of tests sent, which just suggests that some units are more pro-genetic in an overall way. And the reason for this still is unclear. One possibility is that reimbursement practices differ between places, and hospitals also might respond differently to even the same reimbursement practices. Another is that high testing hospitals just have more genetic resources, and this is supported by the idea that generally in healthcare, capacity leads to utilization. So, if you have more genetic counselors and more geneticists, you're more likely to do genetic testing. That seemed true in our data, and maybe that's one explanation. Another is that there are just cultural elements that some hospitals just embrace new technology earlier. This has been discussed as in other contexts, for example, ultrasound technology and other types of new technologies, that some hospitals are just early adopters and they tend to adopt a lot of technology earlier. And then one concerning possibility is that there is some element of bias, and maybe hospitals are offering testing to different people in an unequal way, and this was suggested by the correlation with race, but we really don't have enough information just based on the database to adequately assess this possibility. And then, of course, there's just the randomness or idiosyncrasy in the absence of guidelines. And as we know, NICUs don't have clear guidelines about who should receive genetic testing, so places just might randomly kind of develop in different ways where they have different protocols and different practices. Further work is needed to really explain what is going on to cause this discrepancy, but this degree of any variation, degree of variation for any reason really in itself suggests some problem, because it suggests that a patient might be more or less likely to get a genetic test just based on where they're born, rather than characteristics of that patient. And so it does call for clearer guidelines on NICU genetic testing. And as Sabrina began with, we were excitingly able to publish this in Genetics in Medicine, and it is published online. I have a lot of people to thank for this work. As I explained before, it was actually a project that I started before as part of my T32 work and run the Scholar program. In my ELSI T32 work, Steve Jaffe is the PI and is one of my mentors, so I owe him a lot of thanks. And Chris Futner has been my primary research mentor throughout fellowship, so I owe him basically like an infinite number of thanks, along with John Flibbett, who's one of my other mentors in the NICU. I provide my information here. I know we have some time for questions, but in case we don't get to anything or you think of something later, please feel free to email me. And in 1 second, if anybody wants my email address, it's here, and I'm going to now take down my slides. Thank you very much.
Thank you, KP. You go by KP.
Yeah.
Great study, and congrats on being able to publish it. There's a couple questions in the chat. I'll start with those. And again, if you're joining us remotely, feel free to raise your hand, turn on your camera, and just speak to everyone. No, we'd rather use chat.
We prefer to use chat. Sorry, it's just structures things a little bit easier.
Does put people remotely at a disadvantage. But
well,
Karen's question was: is this exploratory study, and quotes, very nice, what would you see as the next step?
That's a really good question. I think that we need to investigate kind of what's going on more in NICUs in more detail. And I've done this to some, also kind of in a zoomed out way. I did a national survey of neonatologists about how they use genetic testing that showed some misapplication of genetic results, but it also wasn't by hospital. So I think I see my future work as kind of uniting these two bodies of work to say, okay, how are individual neonatologists thinking about this? What is the culture of genetic testing, and using, for example, collaboration with genetics in an individual hospital, and how does that correspond to the overall level of testing? So we can get a better sense of like, what are the workings of each NICU that either lead to more or less testing, and start to address the question of, okay, what really is the right amount of testing? And Sabrina just posted in Educating Neonatologists. Yes, certainly. I think if we had a better answer about what is the right amount of testing, who should be tested, and that would involve a lot of education of neonatologists. And it implies that that right amount would be the amount that neonatologists know how to use, which I think everybody agrees that neonatologists are very much in need of more education in this regard.
Question from in the room, and then I'll go to Tracy.
Yeah. Katharine, this is Becky Kronk, and congratulations on your baby too. It's awesome. Wonderful study. I just had a question. Were you able to discern through the coding newborn screening? Like, was that ever coded as genetic testing, or were you able to take, can you talk to that aspect?
Yeah, that's a really good question. It should not be coded as genetic testing. The codes that we included should not have included genetic newborn screening. However, one hospital, the reason we excluded one of the hospitals was that they had miscoded the newborn screens and basically had like 100% of patients tested because of this. We looked at the data and, as I'm saying, caught that error, but it's possible that other hospitals like might have made smaller scale errors that we didn't catch. And I think just an inherent risk of using a large scale database like this.
Question from Tracy Weiler, can you cross-tabulate against hospitals that have genetic fellowship training programs or established genetics clinics?
That's a really good question. You could do that. I didn't do it. I did look at the hospital websites and extract the number of geneticists just as listed on their website. So I could look at the correlation with that, and it was correlated with the amount of testing, but you could similarly do that for the characteristics that you're suggesting. And I hypothesize that probably they would be related because all the information that we've seen so far suggests that having more genetic resources does lead to more genetic testing.
Any other questions from the? Okay, so thank you, Katie. And our next talk is going to be Sarah Roth. I'm going to introduce her from here instead of walking up. Go up to the stage, I'll introduce you. So Sarah, it turns out, as we discovered a couple of years ago, is a neighbor of mine. And sometime in pre-pandemic, and even Sarah and I cannot reconstruct when it was, we met to talk about futures and careers and what she wants to do and should do and how to get there. And I remember very distinctly her trying to decide between doing counseling, genetic counseling and research, getting a PhD, doing history of science, which is what she was doing at the time. And I don't remember what I told Sarah, although it's a great conversation, but it looks like Sarah decided just to do it all. So after getting a degree in creative writing from Notre Dame, maybe a long time ago, but she has since gotten a genetic counseling degree from the Hopkins NHGRI genetic counseling program, which is a very research-oriented genetic counseling program. And she's currently a PhD student at Hopkins in the medical anthropology group. And her project is exploring gender identity and genetic diagnosis. And just like her approach to doing it all, she also has a long list of mentors. She's a village being mentored. Primary mentors are Audrey Squire and Daniela McKenna, who I don't know if they're on. I guess they're not on, that's why they're not introducing her, as well as the LGBTQIA+ project group is serving as a group mentor for this project. So I'm going to turn over the microphone to Sarah.
Thanks, Larry. I appreciate that. And yeah, it's not often I get a shout out for the MFA in this kind of context. Well, yeah, good afternoon or good morning, everybody, and thanks for having me today. Again, my name is Sarah Roth, and I'm a 2023 ISCC-PEG scholar who I was mentored by Danielle and Audrey, and though they aren't here this morning, I am sending my shout out to them into the ether for their support and mentorship throughout this project. So my project, which I've titled Multiple Weights Off My Chest, has taken the form of an interview study exploring gender diverse experiences of hereditary cancer care. As I begin, I'd like to take a moment to reflect on the words of queer theorist Eve Kosofsky-Sedgwick, who, upon being diagnosed with breast cancer, famously said, "Bleep, now I guess I must really be a woman." In this critical juncture, Sedgwick highlighted the idea that a cancer diagnosis, and in particular one like breast cancer, can carry social meanings that are deeply gendered. For many, a diagnosis brings up pink ribbons, stacks of Better Homes and Gardens magazines and waiting rooms, an aesthetic that the anthropologist Lachlan Jane has called a redoubling of femininity. When I first read this quote, now about a decade ago, my family was in the midst of its own journey with cancer care, and I was grappling with its gendered meanings. It was a mix of personal experiences and critical explorations that led me into this current exploration of how gender identity intersects with cancer care, and in particular for those who are queer and trans, for whom the healthcare system is not built to accommodate. This research is my attempt to explore these questions and bring a deeper understanding of the issue to the genetics and genomics and genetic counseling community. So with these words in mind, let's dive into this study that I conducted to explore the intersections between gender identity and cancer care. So in this talk, I'll start out by discussing the background and rationale for the project, then I'll walk you through the methods and preliminary findings of the study, and lastly, I'll gesture to some clinical implications and next steps moving forward, and also give people shout outs along the way for helping support the project. Before we begin, though, importantly, I like to just take a moment to introduce some important language and concepts that I'll be using throughout the talk. So here, I'll use the term gender identity to refer to an innate and felt identification with a gender, while gender expression refers to how a person expresses themselves. As you can see in this gender unicorn infographic, which I always love to bring in, both because it's stylish and informative, both gender identity and expression exist on a spectrum and are not limited to binaries. So transgender or trans people, a term that I'll be using, identify with a gender that differs from their sex assigned at birth, while non-binary people don't identify exclusively as male or female. Gender diverse, a phrase I'll be using, is an umbrella term that describes both trans and non-binary people. Cisgender people, on the other hand, or cis people, identify with a gender that doesn't line up with their sex, or that does line up with their sex assigned at birth, importantly. So now that we've touched base a little bit about language, let's talk about gender diversity in the US and what we know about it. So we know that a significant proportion of the population with a higher percentage of kids identify as gender diverse. This group of individuals may experience gender affirmation across multiple dimensions or domains, socially, psychologically, medically, but they also face marginalization and stigma, which can affect their ability to access healthcare. While the word trans became more commonplace in the 1990s, especially in the States, gender diversity has a deep social, political, and medical history. And the books that I've screenshotted on this slide are excellent studies of this history if you're interested in learning more. So to develop this project, I turned my attention to what previous research on gender diverse experiences in genetic counseling says. And this research is somewhat limited, though it is emerging in present moment as more and more folks are turning their attention to it. So the existing research has primarily focused on provider experiences, largely looking at biases and areas of uncertainty in medical practice, specifically in the prenatal and cancer care settings. Only a couple of studies have included gender diverse voices, and these studies are limited to info that hews tightly to the clinical encounter. While it's a little bit limited, the available research tells us that gender diverse folks face discrimination in medical settings, widespread disparities in health outcomes, and that there are limited trainings available, in particular in the genetic counseling context that focus on trans health issues. In the context of cancer genetic counseling, importantly for this project, gender diverse folks receive risk assessment, counseling, and standards of care based on risk figures and norms that have really been developed for presumed cisgender individuals, both kind of at the broad epidemiological level and at the level of individual clinical practice. And this project was really aiming to address these gaps in care and knowledge. So the main objective of this project is to gain a deeper understanding of the unique experiences, care journeys, and unmet needs of gender diverse folks who have elevated risk of cancer. The research design included an exploratory phase where participant observation was conducted in a virtual peer support community, as well as the piloting of an interview guide. This was followed by the main phase of this study, which took place between May and October, where semi-structured interviews were conducted with participants lasting between 1 and 2 hours over Zoom, though they tended to sort of skew longer because these were very sort of free-flowing conversations, and I really tried to let interviewees kind of lead the course of the discussions. Data collected was then analyzed through the process of developing a code book with rounds of iterative coding and analysis. And presently, I'm working on writing up the results for publication. So the study included interviews with a total of 19 participants who have hereditary cancer syndromes or significant personal or family histories of relevant cancers. I interviewed 12 non-binary folks and 7 trans folks. Most interviews were with young adults. Most folks had a genetic diagnosis of BRCA1 or 2 or HBOC, and interviewees were mostly white. Additionally, it's important to note that all but 1 participant were assigned female at birth, and only 1 participant was assigned male at birth. So here I'll transition into focusing on 3 broad themes that emerged throughout interviews, connecting gender identity and experiences of hereditary cancer care that emerged through the interviews. So firstly, participants described experiences of gendered stigma, discrimination, and dysphoria in clinical care, which shaped their capacities to feel safe and empowered as gender diverse patients. Secondly, participants explored how gender identity and genetic diagnosis were intertwined in their care journeys for them. They discussed how receiving a genetic diagnosis impacted their visions for gender-affirming care on the one hand, and they also discussed how their gender identity affected approaches to cancer risk management on the other hand. Specifically, they noted that receiving a genetic diagnosis opened possibilities for accessing gender-affirming care. That said, navigating medical recommendations for reducing cancer risk while gender diverse also introduced new forms of medical uncertainty. Throughout these discussions, participants described personal experiences of gender fluidity and underscored an importance of clinicians recognizing that gender transcends a binary. Finally, across interviews, participants made recommendations for how providers in hereditary cancer care could better support them as gender diverse patients. And in the next couple of slides, I'm going to dive a little bit deeper into these themes and share a few quotes that stood out to me from specific interviews. So across interviews, participants reflected on the difficulty of navigating medical care as trans and non-binary folks. They shared accounts of challenging experiences ranging from overt discrimination to subtle microaggressions in clinical contexts, which reflected gendered norms that they also encountered in everyday life. Zoe, and this is the quote on the left, a non-binary BRCA1 carrier, named an explicit experience of discrimination that they experienced. After Zoe received their genetic diagnosis, they met with a plastic surgeon. They had a strong sense that they wanted to pursue a risk-reducing mastectomy without reconstruction as part of their care. But when they shared this with their plastic surgeon, the surgeon responded that they don't serve trans people. Many participants shared that even when providers weren't acting in overtly harmful ways, they still experienced gender dysphoria navigating certain clinical environments that were designed as feminine spaces. For many, the physical spaces of clinical environments were difficult to pass through as sort of passage points. Imaging appointments and waiting rooms were specifically often cited as uncomfortable passage points. And folks discussed strategies they use to help them feel more secure passing through them, like bracing or anticipating the possibility of harm. In the midst of a fraught care landscape, some providers did stand out as affirming in participants' narratives of care. Participants described feeling supported when providers expressed allyship explicitly and used techniques that I'll circle back to that helped create a sense of safety in the midst of somewhat difficult experiences. Throughout the study, participants explored how their genetic diagnosis and gender affirmation journeys were intertwined for them. Many participants reflected the sentiment shared by Ben, a trans guy with a BRCA2 mutation, and this is the quote on the left, feeling able to access gender-affirming care through their hereditary cancer care, as insurance would cover procedures relating to cancer risk. Jay, a non-binary person with a BRCA1 mutation, the quote on the right, reflected on how they felt about their mastectomy after the fact. They shared that they understood that mastectomy and top surgery, technically speaking, were different procedures. Nonetheless, they were both embodied in their cancer risk management interventions. They said, "I know the surgeries aren't the same, but symbolically, mastectomy holds the same feeling for me as top surgery. It's also like multiple weights off my chest because it's gender, it's cancer risk, it's, self-image, it's everything." Many participants shared a sense that receiving a genetic diagnosis that conferred elevated cancer risk felt like a turning point in their relationship with their gender expression. One participant, Fern, reflected on complex feelings associated with the moment of diagnosis, which crystallized dysphoric feelings he had been holding about his gender expression at the time. "I'm not sure if my egg would have cracked if not for the diagnosis," Fern said. "I've thought about it a lot as a turning point, like this moment where the possible futures I envisioned for myself collapsed, but also other ones began to unfurl." For Fern, the moment of genetic diagnosis with its attendant cancer risk alerted him to their discomforts around his then femme presentation. Fern noted that he would not have likely pursued surgery as part of his gender-affirming care if not for the genetic diagnosis. That said, he felt that his cancer risk management and gender-affirming care were tied up together. Navigating hereditary cancer care and gender-affirming care together brought up a wide range of intense, mixed feelings for participants. Jax, a non-binary BRCA1 carrier, described the ability to access surgery as a BRCA1 carrier as a privilege that I don't necessarily want and would not choose to have. On the one hand, the diagnosis provided a tool for stepping over the complicated gatekeeping that many gender-diverse people face while trying to access care. On the other hand, it brought up feelings of fear and anticipation relating to the cancer risk. In describing their experience, Jax noted that there is both the euphoria of inhabiting a body expressive of the gender that they felt, but there's also the trauma of trying to survive cancer. Navigating cancer care, they felt they were stuck between these two emotions. Overall, these emerging findings highlight the complex and nuanced ways in which genetic diagnosis and gender affirmation journeys are intertwined for gender-diverse folks with hereditary cancer syndromes. It also reveals the need for more affirming and inclusive care for this population and the importance of providers being aware and cultivating sensitivity to the unique needs of trans and non-binary patients that they will increasingly be encountering in their everyday care. Drawing on, yes, okay, sorry, I lost myself in my notes. Drawing on reflections from their own experiences of both difficulty and affirmation, participants provided valuable recommendations for clinicians on how to better support them and other gender-diverse patients. These recommendations are as follows: working to avoid making cis-heteronormative assumptions about patients and their preferences, which means being aware of and avoiding making assumptions based on traditional gender norms and roles that we're socialized into. being attentive to gendered language and using gender-neutral medical language when possible, which means being mindful of the language used when talking to patients, and then also using terminology that's inclusive and respectful. Thirdly, partnering around difficult care decisions, which means working closely with patients to make decisions about their care and taking their unique needs and preferences, especially when they're given voice to explicitly, into consideration. And finally, validating and normalizing patient preferences. So acknowledging and respecting patients' choices and preferences and not dismissing or invalidating them. So reflecting on our findings, the study has a couple possible takeaways for clinicians working with gender diverse patients and also working in the hereditary cancer care context. I like to return to this article by Call et al. Published in 2021 about what it means to adopt a gender-affirming care approach. So according to Call, adopting this approach means prioritizing the needs and preferences of patients rather than imposing cis-heteronormative assumptions onto them. Additionally, by taking into account participant recommendations and descriptions of how risk and identity fit into the broader weave of their lives, providers can better equip themselves to respond to the social and emotional needs of these patients. This means being attentive to gendered language, partnering around difficult care decisions, and validating and normalizing patient preferences. The study, even in its kind of nascent emergent form, emphasizes the need for an inclusive and sensitive care environment for gender diverse folks with hereditary cancer syndromes, in which providers listen, understand, and are sensitive to the unique needs and experiences of these patients and their families in order to provide the best care possible. So in terms of next steps in this study, currently I'm taking the manuscript that I've written with these broad overarching themes, and I'm adapting it for submission to the Journal of Genetic Counseling. I'm also sort of personally and along with my collaborators setting up a sort of medium and long-term research agenda in this area. And then I'm also honing in on these themes with some additional writing projects. Specifically, I'm contemplating how folks describe responding to barriers that they encounter in clinical settings, something that I didn't necessarily highlight here, but that I'm exploring further, I think, in my next piece of writing is how people describe what I'm thinking of as care choreography or care hacking, specifically in regional contexts where there's a lot of transphobic legislation and like broad structural barriers that make it especially difficult to access gender-affirming care, and the role that the genetic diagnosis and the hereditary cancer care can take in bridging that access. I have a ton of people to thank who have been helping me work on this project. Audrey and Danielle have been my ISCC-PEG mentors and have gently and supportively been meeting with me on a regular basis to talk about this work at its many different phases. The LGBTQI project group I have been working with, and specifically Layla and Kellen, have served on the committee for this work. Force, the Breasties, and the Vassar Center all helped me connect with interviewees and also provide really lovely, Force and the Breasties in particular, provide queer and trans support group spaces that I have traversed personally and professionally for this project. And then all of the folks at the JHU NIH Genetic Counseling Training Program who kind of helped me become a genetic counselor and conceptualize this project, including Layla, Jill, and Kellen on my committee. And finally, definitely like to thank everyone who participated in this study for entrusting me with their voices and just getting so vulnerable and honest and open with me about these very raw experiences. And yeah, thanks. If we have time, I would be very happy to receive questions.
Okay, we have time for a few quick questions.
Hi, Eva Willoughby from the Ohio State Genetic Counseling Program. A question I had is about a concern that has come up in other research done in this space about gender-affirming therapy, hormone-based therapy, increasing cancer risk outside of hereditary risk alone. Was that a theme that came up in these interviews at all? I'd love to hear more perspectives about that.
Yeah, that's a really good question. Definitely when a lot of folks described receiving the genetic diagnosis and then suddenly having a lot of indeterminacy and uncertainty, like doubt cast on their ability to access hormones in particular, because there is a lot of uncertainty around the long-term effects of hormones. Generally, my sense is that the standard of care is that, receiving the importance of receiving gender-affirming care kind of trumps the uncertainty associated with hormones in terms of long-term use. When I talk to clinicians working in the gender-affirming care space, they're like, people need their gender-affirming care, and we need to just really underscore that when we're talking about this specific, problem or issue of gender identity intersecting with cancer risk. So that's the first thing I'll say. But the second thing I'll say is that when young people especially are at crossroads where they're making decisions both about cancer risk management and gender-affirming care, and they're talking about going on hormones, these are, the long-term cancer risks associated with hormones are on the minds of both them, their family members, and their providers. And there's a lot of sort of complex, hard, shared decision-making made around that. But yeah, it's a good question, and it is sort of an important node in this space where a lot of ethical and social issues are negotiated for people.
All right.
Oh, last question? Yeah, last question.
Okay. Thanks, Sarah, for the presentation. I was going to ask if, for your long-term research plans, are you looking at the psychological impact of, receiving risk information from genetic testing, and also how that collides with gender-affirming care, the impact it has on the participants?
Yeah, that's a good question, and I think I heard it. I think you asked if I'm interested in looking at the sort of long-term psychological impact both of receiving genetic test results and of navigating gender-affirming care. Is that your question? Okay, great. I'm definitely interested in the sort of longitudinal care journeys that people traverse in these two intersecting spaces. The study, as I carried it out here, was a cross-sectional one where I was really dropping in with folks at one point in time in their care journeys. But because I am continuing on with my anthropology PhD, I am really interested in and thinking about following up with a little cohort of folks over time and talking with them about how each of these journeys are evolving for them, because as we know in genetic counseling world and just all of us as humans, like how information sinks in and takes shape in our life over time changes. And so I'm definitely interested in that for folks. And I think the participant observation piece offers a little more of a longitudinal connection with folks, more than just dropping in for one interview. And that is one way in which I'm sort of keeping in touch with folks over time. Good question.
Yeah, I think we have to.
I was just going to clap for all the mentors and
no, those were great. And I just say with the LGBTQ plus project group, I think there's a real gap in health professional knowledge, and we can really hopefully work with you. We should probably find reps from different organizations so the stuff that group is creating can actually be disseminated, especially if there are guides for care and things like that. And there might even be project groups in all the different, work groups in different societies who might be able to connect. So something to think about. So we're doing the grant stuff. Great.
The grant stuff. Dave Kaufman, you can introduce yourself.
Yeah, this is the part where we give out the money. Hey everyone, I'm Dave Kaufman. I'm a program officer at NHGRI in the Division of Genomics and Society, where we manage the ELSI grant portfolio. So, and my colleague Simona is going to talk a little bit about grant getting, grant writing for genomic medicine grants. But we in the ELSI program are very interested in lots of the issues around medicine. We've heard about some of them, I think, from the last couple of talks. And we would love to have applications that are clinically oriented with clinicians on them. So here I am to give you a quick little introduction. And I put ELSI in parentheses or brackets, I guess, because we weren't sure how much experience you all have applying for NIH grants, and no one can teach anyone exactly how to do that. But I just wanted to give you a little bit of sort of help, a couple of tools, just generally as you think about getting grants from us in general. So, with that, you can see me at the bottom there, and my two colleagues, Renee and Nicole. As a group, we administer the ELSI program. And the reason I'm showing you us is because we are program officers. And one of the most important things you can do when you're getting ready to submit a grant, even before you are getting ready to submit the grant, you're getting ready to write it, is to reach out to program officers who you think might be interested in the idea you've got, to talk to them about it and hopefully get some feedback as to whether it fits their mission and whether you fit some things are person-specific as well. So which is my next slide, before submitting anything, really before you start to write, talk to a program officer. A program officer can answer all kinds of questions like, is the science that you're proposing appropriate for your institute? There are lots and lots of ethical, legal, and social issues, implications, questions in biomedicine that have nothing to do with genomics. And there are other folks who are interested in those, but at Genome, we focus on the genomic ones. That's just an example. Is my idea a good fit for the funding announcement? Is it too big, too small? Is it, are there other funding announcements that might be a better fit? And have I made any big mistakes? And that's, of course, with not your entire life, but but just in your sort of plan to submit a grant. So, your next question is, well, program officers, there's a lot of you. Who should I contact? I mean, and just saying go to the NIH website is really not very helpful. It is vast, and so. There is this tool. There are lots of tools, but I really like this one in order to find program institutes, program officers, and other researchers who might be interested in the kinds of things that you are interested in. It's called Reporter, and on the Reporter website there is a link to Matchmaker. I should have noted that here on the slide. So if you go to Reporter, you may look for Matchmaker, and it's cool. You can copy and paste pretty much any text you want. You can put 2 words, underserved genomics, and you'll get something back. You can copy and paste an abstract of something you've written or something someone else has written, and paste it in there, and you get back is it perfect? No, but you'll get back lists of grants that have been funded across NIH that the computer thinks are an interesting match to that, sort of ranked by match. You can look and see how you can organize them by which institutes. You can see which program officers are funding those things, which calls for applications. It's a really neat tool. You can spend all day with it. But it can really help you narrow down to, like, you can try a few different searches and kind of triangulate on people. I really like it, and I think if you're starting out with an idea and where on earth do I go in NIH, it can give you clues. You should also learn about different funding opportunities. There are new ones all the time, not necessarily, and the place to go and look for those, or one place to go. There are more targeted ways to get information. For example, NHGRI has a listserv you can get on, and I'll make sure I put that link in the chat. We've got a listserv that you can get on, and you'll get all of our funding announcements. But this NIH guide has pretty much everything. And sort of find grant funding might be a little optimistic. It's like, oh, here's the funding. I just, found it. I mean, this is finding grant opportunities. So, but it's highly searchable. You can focus on institutes. You can focus on different parts of NIH, different parts of the government. It can be a bit overwhelming, but it does help you kind of keep current. You can save your search, and so if you're interested in bioethics, you can save that, and you can get something back on a daily basis if there are any new bioethics opportunities, for example. So quickly back to NHGRI's ELSI research program. We've been around since 1990. Our mission is to anticipate and address the ethical, legal, and social implications of genetic and genomic research. We've got 5% of our extramural, that's money we send out to the bigger community budget, set aside for this program, and that translated to about $23 million in fiscal year 22. About half of that money, maybe a little more, is dedicated to investigator-initiated research, and that's research where someone out there has an idea, they put together a grant, they send it in. We haven't asked specifically for stuff on that, and we fund it. So that is to say, your ideas matter to us. You are out there doing things, seeing things that we haven't yet imagined. So what are we interested in? I mean, usually any idea is interesting. Well, we do have a lot of stuff written about things we are interested in. We've got sort of 4 broad research areas: genomics and sociocultural structures and values, genomics at the institutional and systems level, genomic research design and implementation, and genomic healthcare. And if you're thinking, I know where I'll go and look first, if I'll go to that healthcare. And so our interests are very, very broad, and we have a website, and don't worry about all these links. We'll send a file out that's got all these links and a few more. But if you go to this web page, it is a very long web page with lots of things written, lots of more specific ideas here. And in the interest of time, I won't spend a lot of time giving you examples of these. But if you look, you might see these first 3 topic areas and say, well, I would just skip to the bottom. There are lots of overlap here, lots of interesting, I think, questions about genomic medicine in these first 3 areas. And these aren't the only ideas. I just said to you, you might have an idea we've never thought of, but this is to get your juices flowing, and then when you come up with an idea that's sort of this or not quite, that's what do? You call a program officer. You got it. So, and you talk to us. Is that in scope? Is it something that's interesting to you all? But there's lots of potential ideas there. And I just want, if you lose the file, all you have to do to get to this page is search ELSI research interests on Google, and it will, the first hit takes you to that research area page. What kind of research do we support in ELSI? There's lots of different things that we do. A big category that's not on here is training, and that and you might be saying, well, I am not an ELSI researcher. How do I become one? And I have a slide or two about that in a second. We do have opportunities for training. They are not on here. That is another vast and important category, which I think we might want to come back to you all and talk about it another time. These are the ELSI program's three main research opportunities, the R01, 21, and the R03. You can just think of those as large, medium, and small. The table down here tells you the R01 is about 3 to 5 years, about $500,000 a year maximum. Less is fine. The R21 is much smaller. It's sort of it's for pilot projects, something that would lead to a bigger project, but maybe you need to try some stuff out, get some initial data. And those are 2-year projects, although we're looking to expand them to 3. And you get $275,000 total spread across the project period. And the R03s are very small grants, only $50,000 a year, and those are typically used for secondary data analysis, secondary research, or in some cases, some of our philosophers, historians who don't need a ton of resources, but just need time can use those. So how do I ELSI? I am not an ELSI researcher, but I'm interested. People ELSI in teams. How do I do ELSI research? People do it in teams. Those teams are highly multidisciplinary. And when I say people, I'm talking about grantees. Our grants are almost always highly multidisciplinary, even the small ones, the R21s. The R03s aren't big enough to be too multidisciplinary. You usually just get one person, or maybe 2. So cuts across disciplines from philosophy to biostatistics, public health, social sciences, clinicians. More on that one second. There are many methods and fields. You don't have to know how to do all of those things. Obviously, no one does. And grants that come in that are focused on clinical questions that have clinical expertise on the grants are often grounded in reality, which is very, very good. If you're working to identify or address problems that are being experienced on the ground, that's a good thing. So we love to see grants with clinical experts as part of it. How do I write a grant? You can learn from examples. Ask other grantees if you can see their grants, things that were funded, things that were not funded. And you can look at grants that we've posted on our website. Again, if you go to the ELSI part of Genome's website, there's a place a little bit called Sample Applications and Summary Statements. We've gotten permission from several grantees to post their grants, post the summary statements, that's the reviews that they get back, and then they can respond to those reviews in a new application if they need to. And the idea is not copy and paste, obviously, but instead, just giving you an idea of what do people say in a grant? What kinds of things do they cover? How much space do people take on different sections of the grant? There are other resources as well to help you write things de novo, but we find that we've heard those can be quite helpful. Finding other ELSI folks and other grant resources. We have a relatively new website, elsihub.org. It's a product of a grant that we're funding, and it has a whole section on funding with funding announcements. There's some videos about developing an ELSI grant, FAQs. They've brought together a lot of the information that you might have to search hither, thither, and yon for on our website. And I'm not saying go there before you call us. You can always call us, but there's a lot of nice stuff right there. There's also a directory of ELSI scholars. You're like, well, I would like to do this, and at my site there's me, and I've got a genetic counselor, and I've got an anthropologist, but I really need someone who does health services research. There's a directory of people that, and it's one place to look. There's also, this is more about grant writing. There's a video archive from 2021. This link isn't on the file that we'll send out, so I'll send that around. It's got like 50 different videos, I think, about different aspects of grant writing, and two of them that we thought would be really good are the grant writing for success, and there's mock review, which lets you see sort of what your grant goes through in review. So this is just basically the same as my first slide. Call us, Zoom us, email us, flag us down. We are happy to talk to you about ideas. You don't have to have anything, you don't have to have a whole lot written. We usually start with those conversations with, you know, if you know what a specific aims page is, it's sort of your goals for the research. That's where we start the conversation, and a couple of paragraphs will do. Thank you so much, everyone. Send us your grants, call us.
Thank you.
Yeah, you're welcome.
We're really happy that Dave could come down in person. You see, they're real people. So, and all the people.
I thought it was a big computer that does everything. So. I'd also like to suggest T-shirts that say, "How do I ELSI?" at the entire. I like that. That was good.
So Simona Volpi is our next presenter, and she's presenting remotely.
All right, so thank you so much for having me today. I'm excited to tell you a little bit more about my division, which is the Division of Genomic Medicine. And thank you to Dave for putting this, before me, setting the stage for this. So definitely I can echo what Dave said about reaching out to us ahead of time. It's always better than afterwards. So I will go through what I thought might be the most interesting funding opportunities that come from my division. My division is, as I said, the Division of Genomic Medicine, which focuses on research that helps to identify genetic contributions to human health and advance the approaches for the use of genomic medicine, genomic data to improve diagnosis, treatment, and prevention of diseases. And I put here two links. One is for the genomic medicine division, and the other one is for training. The first one has the link to the FOAs, the funding opportunity announcements that are more relevant for our division of genomic medicine. And it's a pretty big division. I'm not going to show you who is in the division because, you know, they have 3 people. We have more. We have around 15 people. So, and each one of us has a little bit more of a focus than on a certain aspect of genomic medicine than others. But if you go on our website, you can search out what you are interested in or through the tools that Dave gave you, and you will find the right person. The other way around is when you look for a program announcement, there is always at the end the contact person. And that's also a very good point of a starting point for reaching out. All right, let me go into what I thought might be the most interesting program announcement that my division of genomic medicine has right now active. All right, so one is called Advancing Genomic Medicine Research. We abbreviated it as AGMR. There are 2 RFAs. One is for R1 and the other one is for an R21. But basically, this is a way for us to stimulate and encourage applications that are advancing the when and where and how to best implement the use of genomic medicine and information and technology in healthcare. So here I put in each slide the date, the expiration, and the contact person. You will have these slides, so you will be able to have that information available. The next one is the Investigator Initiative Research in Computational Genomics and Data Science. This is this is a PAR. So hopefully you know the difference between an RFA and a PAR. RFA, it's usually when we set, we have a set amount of money for that particular initiative. PAR tend to be more general, meaning that the pool of money is coming from whatever is available. There is no set aside money. This FOA, it's more focusing on computational genomic, data science, statistic, bioinformatics, clinical genomic science, and it's really focusing on that, which has to apply to clinical care. When you think about genomic medicine division, it's always about clinical care. The next one is we issue a special interest, a notice of special interest. So sometimes what we do is say, well, we realize that we are not really have a lot going on in this field. We really would like to receive more in this particular area. And that's where we are, we issue the notice of special interest. In this case, it's about development and implementation of clinical informatics tools to enhance patient use of genomic information. In this case, Renee is our contact person. I put here the link to the NOSI, and it's basically encouraging application to develop and implement patient-facing genomic-based clinical informatics tools to facilitate the patient-provider electronic communication, patient tracking, patient self-management support, and all of that. The next one I thought it was an interesting one that could be an interest for you is the mentored research experience for genetic counselors. This is an R25, it's still a PAR, but it's basically focusing on providing genetic counselor with research experience. They have to have the people, in this case, a master degree in genetic counseling, no doctoral students, so research experience goes from 12 to 24 months, and it has to be a full-time commitment or a minimum of 50% of full-time professional efforts, a maximum five years. So if there is somebody that is a genetic counselor that is interested in maybe improving their and adding on to their expertise, a research aspect, this is a good way to start. The contact person is Heather. Heather is, I send it also in the chat. It's also our contact person for training. So the next one is supporting talented early career researcher in genomics. So this is an RFA. So we have set amount of money to help fostering this initiative. And it's really to support research projects that are driven by exceptional and promising early stage investigator with long-term career interest in pursuing genomic research. Lisa is our contact person. Now, I wanted to go a little bit into more details of what the training and opportunities are. And we actually have a dedicated team for training. I'm not part of that, so I apologize if I can't answer questions about the training, but definitely I put in the chat, the contact is Heather, which is in charge of the training. And also we have Lucia. We have created recently a separate office for diversity and training. So Lucia is in that office, so she will be able to help you with that, with training and diversifying the genomic workforce as well. But basically, this is a list of opportunities that are around training. So we are interested in undergraduate and post baccalaureate training. So there are here a list, you can see a list of activities, of opportunities that you can look at it. Also at the master level and predoctoral training fellowship, those are also of interest. At the bottom here, I put the link for the Thai office. Then there is also for a training for those that are clinicians and they are doing a residency. So those are the one that they are active right now. And then there is a postdoc and early stage investigator training. So here is the list of activities, code and PARs that might be of help. Last is a list of still RFAs and PAR that might be of interest if you are want to focus on training and diversifying the workforce. Among all of this, I pull out a few that I thought were particularly of interest. This one is the first one. It's an RFA, and it's pretty recent. So new investigators to promote workforce diversity in genomic, bioinformatics, bioengineering, biomedical imaging research. So this is a collaboration that we have with the Institute of Biomedical Imaging and Bioengineering and all of us. The program is intended to support early stage investigator and new investigator from a diverse background, including groups from underrepresented sciences. Contact person, Jyoti here. Another one I thought it was of interest is Diversity Center for Genomic Research. These are U54. It is still an RFA. And here, the goal is to really establish genomic research center at minority serving institutions. And there is a definition of an MSI that you can find if you Google the RFA number. And the project has to focus on clinical issues, critical issues in genomics. And here there is a list of those that might be of interest, that are of interest of ours. And also, beside having, scientific goal, the centers need to focus on diverse genomic scientists, clinicians, research that can perform the genomic research. The contact here is Ebony. Now, the next one is an award that it's called Support for Research Excellence in Award, or SURE. It's a PAR, and this one is really awards that provide research grant support to faculty investigators who had prior experience in leading external funding independent research, but are not currently funded by the NIH program, with the exception of this award. And the contact here is Lisa. So I think with this is my last slide regarding the type of initiatives and opportunities that we have in my division.
So thank you both. If you wanted to come up and just by a microphone, thanks. So I actually had a question. So what about the R25 grants that were purely courses for skills development? Are those no longer available? Are the only R25s related to creating a research program, like a research experience?
Which I think they are still.
Oh, no, because she didn't mention them, so I just want to make sure, because actually those are probably the ones we'd be most interested in this group.
Those are for individuals, right?
Yeah, there are 25s.
We have so much going on in training, it is very, very hard for us to keep track, but they are still out there. I think this May, I was just looking at it, I think this May is the last receipt date. Maybe, that doesn't mean forever, but that means
For this PAR.
Yeah, we would need to re-up.
Because I encourage people to look at that one, because that one is really, I think if it's the same grant it was, and maybe if you guys could find the one that's active, and we could put it in the chat or something, because
It's no problem, I'll do it.
because there's two different levels of funding for that, and that's to really create courses. The other question I had related to education, is there a grant to have a conference?
Yes.
Yeah.
Okay.
I
So
think
that's
there
a
are
one-time type of thing you can do as well. So I think those two would be ones that the other ones are also very important, and I think the R25 especially for creating a summer research experience, and I know some people sitting right here have been involved with some of those. The other quick question I had is there still early investigator advantages, and do those apply to both the research and the R25 grants? Do you know what I'm talking about? Are there some? Do you get something for that, or?
Well, it's not like we sort of
prioritize.
If
you're a free pass.
Exactly. There's not like a formula. We don't. So for some reason, a lower score is better. It's not like we subtract 10 from your score and automatically if you're new. But at least for the ELSI grants, and Simona, just jump in for the ELSI grants, the new investigator grants and early stage investigators, they're reviewed in a little clump together, so the reviewers are aware, and then we always try to prioritize sort of, maybe not even all things being equal, but certainly all things being equal, we try to prioritize those, and even sometimes when they're not, we try to prioritize. Yeah, okay. So it is still out there. I mean, it's a little mushy as to sort of what you get, but. I thought there was we actively take that into consideration. Yeah, it's a goal.
I'll just there's a comment. There is the training for genetic counselors and people involved in genetics, and the question was raised about training or support for to train people who are non-geneticists. And I think there is a grant that was proposed for like laboratory professionals or.
There's one for like technical, like for
right, like,
for like
but I think that's
I think you're right.
Yeah, the idea is they wanted to start, I would guess, in their sweet spot, but I think that is something we can communicate and continue to emphasize, and that's why the R25 to create a course is not specific. If it's the same grant, is not specifically for genetics people. I believe it can be applied to almost any group, and I think I've been involved with an R25 with the NCI. And it's a way to get some salary support and some other things to really, and I'd be happy to talk to people. I mean, every institute is different, but maybe if you guys could just pass that on. But I know we're running late, but thank you both for taking the time to tell us. And we're glad you want us to talk to you.
Absolutely.
So please, and if you have trouble getting in touch, the Extramural folks are great and always willing to help and talk about. I've talked to my program officer too. It's a good thing to do, so we shouldn't be afraid of you.
No. Okay. I mean, everyone's like, oh my gosh. No, I mean, we have no power. Our power is to try and help you. So
Great. Thanks a lot.
So yes, thank you.
Thank you. Bye-bye.
Dave and bye, Simona. Thank you. Yes, thank you. And we will be sure to pull together the information that Dave and Simona put together, as well as Heather Colley brought up training information that I passed out during the breakfast. We'll put that all together and send it out to you all. So I have a few announcements. We are running a bit late, but the way we've got the schedule worked out, I think everything will work out just fine. First of all, I want to say my colleague VJ in the back has okayed taking a photo of our group, so don't run off just yet. After the announcements, we'll all get together in front of the screen and he'll take a picture. So if you ordered a lunch, they are in the lobby of this floor. This was the pre-ordering. If not, many of you passed by the first floor cafeteria in the A wing, so you have to move from the C wing to B to A to get to the cafeteria. There's a few vending machines as well. So we're moving into our lunchtime. I will say that if you drove here, we do have parking permits available, and Roseanne can help you with that. So after the picture, we're going to move into our working sessions. And we're really excited that we are having a hybrid meeting, and Gerald and his team have done an amazing job getting everything all set up. So we have 10 project groups, and after we're finished with the photo, you'll see another list of where to go. But if you're virtual, you will be sent automatically to the room that you selected during registration. You can also move around if you're virtual. If you're in person, you can move as well, but most of you are pretty dedicated to a single project group. And I know some of the project groups have a very distinct agenda, things they want to accomplish this afternoon. So, you know, that's your decision. So finding those rooms, Roseanne and I will help. There are some rooms, the easiest to find rooms are right here on this floor. You probably were in the C room. If you were here for breakfast, there's a D and an E room up here on this floor. But the rest of the rooms are on the floor that our branch uses as offices. So Roseanne and I will walk you down there to your individual rooms. And each of these rooms, again, thank you to Gerald and his team, is already set up with a laptop so that you will be connected to your virtual attendees. Okay? So I think, just a reminder, the project group co-chairs will be asked after the working session to give a 5-minute update. And that's during our 3:45 to 4:45 project group summaries and ask session at the end of the day. So it's with so many project groups, it's a very brief update that you're going to provide. Okay, any questions? Okay, we've got a photo and then lunch and then moving to your project groups.
And just quickly, there's this info sheet too, right? For the
That I made a limited number of copies, but sure, I will pass that on.
Okay.
With all of the electronic information about funding.
Okay, so photo time?
Photo time, yes, something. And yeah, here we go in front of our ISCC-PEG info.